Welcome to our MyIBD Learning virtual program, Impact of IBD on Diet and Nutrition. My name is Rachel Meltzer. I live in Jersey City, New Jersey, where my husband and I are very proud parents and caregivers to our two kids, now aged 12 and 7, who both have ulcerative colitis. Tonight, we plan to explore the complex relationship between inflammatory bowel disease and nutritional health. Our expert presenters will discuss digestion in IBD, malnutrition screening, common nutrient deficiencies, and the importance of hydration. Considerations for special populations will also be highlighted. Be sure to stay until the end of the program for additional resources from the Foundation on diet and nutrition. In order to make the program more interactive and find out how much you've learned, tonight, we'll be asking two questions via a poll on your screen now. Let's start with tonight's first question. How often should an IBD patient be screened for nutrient deficiencies if their disease is active? Directly underneath, you'll find our second question. Which of the following is the most common nutrient deficiency in IBD patients? I'll give everyone a few seconds to make their selections. At the end of the presentation, we'll ask these questions again and see how much the group has learned. Thank you for your participation. It looks like most people selected every 3 months for question 1 and vitamin K for question 2. Let's listen in on the following, let's listen in to the following presentation to learn more. On behalf of the Crohn's and Colitis Foundation, thank you all for joining. The information shared is meant to be for educational purposes only and should not replace any advice or guidance from your own healthcare professional. The program will be recorded and posted on the MyIBD Learning website, Crohn's and Colitis Foundation, crohnscolitisfoundation.org/MyIBD Learning, and everyone who registered for the program will receive a link with the recording next week. We want this to be interactive and engaging for you, so we encourage you to submit your questions through the Q&A box, which can be found at the lower part of your screen. Following our expert discussions, I will moderate a Q&A session with all of our panelists and will address as many questions as we can at the time. Tonight, we have the opportunity to hear from 2 registered dietitians and a gastroenterologist. Our first presenter will be Lori Beacon. Lori is a registered dietitian who has worked in the acute care setting at Scripps Green Hospital for more than 15 years and has transitioned to working in the outpatient gastroenterology clinic at Scripps Clinic Torrey Pines for the past 5 years. Lori specializes in working with patients with a variety of autoimmune diseases with a primary focus on inflammatory bowel disease. Our second presenter is Brittany Rogers. Brittany is a registered dietitian and founder of Romanwell, an insurance-based telehealth practice specializing in IBD, and has personally lived with ulcerative colitis for over 25 years. Lastly, we'll hear from Dr. Stephanie Gold. Dr. Gold is an assistant professor of medicine at the Icahn School of Medicine at Mount Sinai and a gastroenterologist at the Mount Sinai Hospital with a focus on inflammatory bowel disease and nutrition. Dr. Gold's clinical interests include nutrition optimization for patients with inflammatory bowel disease and the use of diet as an adjunct therapy for patients with Crohn's disease and ulcerative colitis. Listed here are our speakers' financial disclosures. Throughout tonight's program, our presenters will discuss the following agenda, which will cover topics around digestion and IBD, malnutrition, nutrient deficiencies, hydration, and a highlight on nutrition principles for special populations. Now, let's get started with tonight's presentation. At this time, I'd like to welcome our presenter, Lori Beacon.
Thanks so much for the introduction, Rachel. I really appreciate it. We'll start by just doing a brief overview of the digestion and differences in ulcerative colitis and Crohn's disease. So when we highlight the differences between UC, ulcerative colitis, and Crohn's disease, we really can better understand nutritional concerns for our patients. So, with UC specifically, we see continuous inflammatory process throughout the entirety of the colon itself. So, this disease is localized to the colon. We often see kind of more of a single surface layer of disease as compared to that of Crohn's, which is multi layered or transmural. So the difference here with the Crohn's disease is it's more patchy and an inflammatory appearance. And most often we can see this from an endoscopic perspective. We see a thickening of the colon wall as well, and kind of more patchy inflammatory response across the entirety of the GI tract. So from Crohn's disease, it affects any part of the gastrointestinal tract from mouth to anus. And we can also see extraintestinal manifestations as well. So when we look more specifically at ulcerative colitis, there are different types of ulcerative colitis, and knowing which type of ulcerative colitis is that our patients are affected by really give us again a better understanding of how we can help them from a nutritional perspective and what puts them at nutritional risk. So, for example, ulcerative proctitis refers to disease of the rectum, and typically symptoms would be more rectal bleeding prominent. Proctosigmoiditis involves both the rectum and the sigmoid colon. Again, more of a bloody diarrhea and stool, and involves a lot of cramping as well. Left sided colitis includes the rectum, the sigmoid, and the descending colon. Again, some of those same symptoms, including bloody diarrhea and cramping, and then also a sense of urgency. Now, pancolitis affects the entirety of the colon and again is more in a continuous inflammatory pattern. From Crohn's disease perspective, there are different types here that we can kind of identify and more target our nutrition therapy, knowing which part of the GI tract is affected most. Ileocolitis involves disease of the ileum and part of the colon itself. This often appears from a symptom standpoint. We see weight loss, diarrhea, cramping, abdominal pain. Ileitis involves the ileum only, and this is where we can also see, again, more weight loss, diarrhea, cramping, many of these commonalities. We also can see fistulas develop. As we talked initially about the transmural kind of multi layered effect of the ulcers present in Crohn's disease. Or the inflammation present in Crohn's disease, we can then understand how these fistulas and other problems can occur as well with the severity of these diseases. There's gastroduodenal Crohn's disease as well, which involves the stomach and the duodenum. So initially, the first part of that small intestine, we can see a lot of weight loss in this patient population and changes in appetite as well, significantly causing nausea and vomiting. Jejunal-ileitis, which affects part of the jejunum, and this is our main area of absorption of our micronutrients. We can see this symptomatically diarrhea, postprandial cramping, meaning after meal cramping, and then also, development of fistulas, as was previously mentioned. And Crohn's colitis or Crohn's granulomatosis, I can never say that word, it involves the colon specifically. And again, we can see a lot of different changes in skin lesions, a lot of extraintestinal manifestations as a result of this as well, skin conditions, dermal, joint pain, inflammatory response there, diarrhea, rectal bleeding, mouth ulcers, and then fistulas as well. So as we've kind of gone over the general presence of the disease states and understanding which parts of the GI tract are affected, we can understand a little bit more about how our patients are at risk for malnutrition as a result of their chronic relapsing and remitting diseases. Malnutrition is defined as a deficiency or imbalance of a wide range of nutrients. This can look like a lot of different things in our patient population, and it doesn't often correlate with patient size, weight. So we'll look at this in a little bit more detail moving forward. So malnutrition affects about 20 to 80% of our patients with inflammatory bowel disease. And some of the factors contributing to malnutrition include decreased oral food intake with restrictive diets primarily. And those are most often, patient seeking and kind of looking on the internet perhaps and trying to kind of find what helps them feel better for the most part. Other factors contributing to malnutrition include fear of food. Knowing that you've had pain from a food before often causes a restriction of that fear of that food specifically. Medication-induced anorexia can be a cause of limiting oral intake simply from lack of appetite. Malabsorptive tendencies, and we'll get into this a little bit more, due to active inflammation or surgical intervention. Increased nutrient demands due to active inflammation. Our body needs more protein, more calories, and we'll kind of delve a little bit deeper into that as well when we're actively inflamed. And then altered anatomy, again, due to surgical intervention. And that's in the case of things like short bowel syndrome or short gut, as it's often referred to. So, looking a little bit closer into some of these causes of malnutrition, we talk about decreased oral intake, and this is directly related to loss of appetite, nausea, pain, fatigue. When you're not feeling well, typically your appetite lowers, and that can be something that's really difficult to keep on track with daily intake, calories, meals, and just being consistent with oral nutrition. Fear of food is probably one of the top reasons why a lot of my clients restrict their diet. They've had problems with it's almost like a PTSD type of situation. They've had problems with certain foods in the past, and they're fearful of those foods again causing further symptoms for them. Um, Maybe even kind of having different tests done that say, okay, you're sensitive or allergic to certain foods. Those tests may not always be valid or accurate. And so, unfortunately, they kind of cause this undue or unnecessary restriction of food. So, this is probably one of the most prominent things that I try and talk to a lot of my clients about in clinic on a daily basis is overcoming this fear of food. And then elimination diets. Now, these elimination diets are meant to be used as frameworks, as guides for our patients. But unfortunately, with adopting these restrictive diets and without proper guidance, most often from a registered dietitian, they can cause over restriction of foods unnecessarily. So what we want to be really mindful of is understanding how diet can really play a significant role in our patients' lives and understanding how over restriction of these nutrients rather than augmenting the diet with certain foods can really cause a lot more detriment than it can be helpful. One of my favorite visuals is of this GI tract where we can see the micronutrients and macronutrients and absorptive sites throughout the GI tract. So I just wanted to really highlight when we have acute and chronic inflammation, it can damage that gut lining, which definitely impacts our nutritional status by impairing absorption of nutrients. So, not only is the absorptive site really called into question, and so really understanding what area of the GI tract is most impacted by disease can be really important and effective when it comes to nutritional considerations. Things like frequent loose stools causing malabsorptive tendencies, bile acid diarrhea. This is often related to surgical intervention. And then, of course, nutrient losses, and electrolyte imbalances due to diarrhea and vomiting as well. So I kind of tried to highlight different colors. When we know that UC is directly localized to the colon, our main concerns from a nutrient loss standpoint have to deal with electrolyte abnormalities, fluid shifts, and losses. And this is where most of our attention is focused on, as well as obviously maintaining weight and all the things that come along with it with our macronutrient load too. When it comes to kind of those green areas, of course, with Crohn's disease, as it can affect the entirety of the GI tract, we have a lot more to be concerned about. And in any case, we can have losses of electrolytes and micronutrients, macronutrients, but primarily we can understand things like fluid shift losses, of course, again, but fat soluble vitamin deficiencies, especially at the ileum, and B12 deficiencies as well. And then macronutrient malabsorption and iron deficiency, which is a very prominent concern in our patient population. So, causes of malnutrition, further increased nutrient needs, as we talked about previously, increased nutrient needs during active inflammation are significant, and this is due to increased metabolic demands for healing. So, our protein needs go from a standard of zero 0.8 to 1, potentially for an average individual, to about 1.5 grams of protein per kilogram of body weight in active disease, or when someone is preparing for surgical intervention. And the calories are increased as well, 30 to 35 calories per kilogram of body weight for active disease, as well as in preparation for surgery. Some side effects of medications can cause nutrient interactions. So, side effects like anorexia, so poor appetite, taste changes, dyschezia, and then again, nausea can impact a lot of those nutrients as well and increase nutrient demands. Sulfasalazine and methotrexate are medications that can interfere with the absorption of folate. So, and that from that circumstance, we need to understand maybe that we need additional folate support or folic acid supplementation. And then, with respect to corticosteroids, often used in treatment for IBD, long-term use specifically can cause calcium losses. So this is, and changes in our bone density. So keeping up with that and considering calcium and vitamin D supplementation is significant as well. So when we look from a surgical standpoint, we can definitely identify, and hopefully these images help guide you a little bit. But when we're looking for nutrients of concern, with things like short bowel syndrome, this is identified as less than 200 centimeters of the small bowel retained, and this may result in significant macro and micronutrient losses, as well as shifts in fluid status. So dehydration is a huge part of this as well. Going across, ileocecal removes the cecum and the terminal ileum, things that we are concerned for in this surgical state. They're higher risk for bacterial overgrowth with the loss of the cecum there. And then consideration for B12 deficiency, as that part of the ileum itself is the main site for absorption of B12, as well as fluid shifts, and electrolyte abnormalities, again, from potential dehydration and losses there. When we go down to that bottom left corner, the J pouch surgery, or otherwise known as ileal pouch anal anastomosis, we are mostly concerned about things like fat soluble vitamin deficiencies, vitamin B12 deficiencies, dehydration, of course, so fluid imbalances. And this is where also fiber plays a specific role in this too. So managing output and the consistency of stool output and how we can, increase hydration and, potentially shift around the different types of fiber that we're consuming. And then on the far right, total colectomy. This is where our attention is focused primarily on fluid losses, dehydration, electrolyte abnormalities, and then of course our macronutrient balance as well, weight loss and all the things that are involved in post-surgical healing as well. So when we are looking for malnutrition in our inflammatory bowel disease patient population, there's a number of things that are being considered. We take definitely a thorough, uh, nutrition assessment. We do in-depth diet recall and really get to know our patients and understanding their relationship with food. And all of these things play a huge role in identifying malnutrition in our patient population. There are two main screening tools that are used and identified as the most sensitive screening tools for identifying moderate to high risk malnutrition. And that's the MUST screening tool and the Saskatchewan IBD nutrition risk tool. These are simply tools that are useful kind of as a checklist to help. Now, if we don't have access to these, or if any other healthcare professional, PAs, NPs, nurses, even anybody that's helping with the care of our patient, the two most important questions that any healthcare professional can ask is, have you recently lost weight without trying? And have you been eating poorly because of decreased appetite? And if the answer is yes to either of these questions, then the patient should be referred to a registered dietitian, preferably one that specializes in GI if they're available. I know that's not always the case, and it may be an ideal world for a lot of people, but getting access to a registered dietitian that has a specialization in GI is very helpful. So I'm going to end there and I'm going to hand it off to my wonderful colleague, Brittany, and she's going to talk about managing nutrient deficiencies.
Thank you so much, Lori, for a great presentation and for the warm introduction. And thank you to the Crohn's and Colitis Foundation for inviting me to speak today. I'm very excited to talk to you guys about nutrient deficiencies in IBD because I feel as though this topic really isn't discussed enough and yet can be a major player in helping individuals with IBD feel significantly better. So let's jump right in. So, why do nutrient deficiencies occur? Nutrient deficiencies occur in individuals with IBD for a variety of reasons. So it could be inadequate dietary intake, and that can occur because of a lot of times people with IBD, as Lori had mentioned, have a fear of food, triggering symptoms, and this can lead to food restrictions of multiple foods and food groups. But it could also be related to GI symptoms such as nausea, decreased appetite, early satiety or fullness, pain or diarrhea, or due to restrictive or therapeutic diets. Increased nutrient requirements can be another cause because active disease can increase the body's metabolic rate, leading to higher energy needs. Increased nutrient loss because blood loss from rectal bleeding can lead to iron deficiency and anemia, and chronic diarrhea can cause dehydration, and the loss of electrolytes and fluids such as potassium, sodium, magnesium, and zinc. Malabsorption, as inflammation and ulceration can damage the intestinal lining, which can impair the absorption of nutrients, especially in the small intestine where a lot of nutrients are absorbed. And protein loss through the digestive tract can contribute to protein energy malnutrition, which can lead to multiple nutrient deficiencies. And an altered anatomy due to surgery can also contribute to deficiencies. For instance, people with ileal resections are often at an increased risk for vitamin B12 deficiency and fat soluble vitamin deficiency. Um, Fat soluble vitamin deficiencies as a result of bile acid malabsorption. And then finally, certain medications can also increase the risk for nutrient deficiencies. For instance, methotrexate can increase the risk for folate deficiency, and prednisone can decrease the absorption of calcium. And therefore, people on these medications would really benefit from supplementation of these nutrients. So, what increases your risk for deficiencies? Pretty much everything we mentioned on the last slide. So, having active inflammation, avoiding multiple foods and food groups, following a restrictive or therapeutic diet, especially without proper support, certain medications that interact with nutrient absorption, and having bowel surgeries. But on top of that, there's also specific sub IBD populations that are at an increased risk as well. So, individuals with inflammation in the small intestine, in particular, because that's such a major absorption site for nutrients. Individuals with long segments of inflammation or multiple sites of bowel inflammation are at increased risk, and children in general, because they already have increased nutrient requirements, but especially when they have active inflammation, that's going to increase their risk of deficiencies. So, macronutrients are essential nutrients that the body needs in large quantities. Examples of these include carbohydrates, proteins, and fat. Calories are really a form of measurement of energy that's provided by these macronutrients. And when you're not getting enough calories, that can occur when you're not getting enough calories. Uh, that can occur due to active inflammation, fear of eating that decreases intake, having restrictive eating, which can all lead to weight loss and malnutrition. And as Lori's talk discussed, malnutrition is really important to prevent and or treat because if you're not getting enough calories to maintain your weight, then you're likely not getting enough calories to devote to wound healing. Protein needs increase when we have active inflammation, and it can be um, sometimes it's not very easy to get that enough of it during flares, especially if you're avoiding multiple foods or food groups. And it's important to eat enough protein because it's another key nutrient that's involved in wound healing. So if you're not getting enough protein in your diet, it's going to be harder for you to get into remission. So, what can you do to prevent inadequate caloric intake? So there's a lot of people who recommend, 6 small meals a day, but if you're symptomatic and you have active inflammation, you're likely exhausted as well. So I don't know about you, but I think it's really hard to cook 3 balanced meals a day, let alone six. So sometimes just reframing this to instead of thinking that you need to have 6 small meals a day, just have 3 balanced meals and then 2 to 3 balanced snacks a day. Keep in mind that quick options like oatmeal or yogurt bowls, smoothies, avocado toast, scrambled eggs, all of these could count as meals or snacks. Drinking smoothies or having oral nutrition supplements in between meals and snacks are also a great option um, because it's often easier for people to drink more calories than it is to eat them, especially if you're dealing with symptoms like nausea or early satiety or early fullness. Other things you can do is add, finishing oil, like a little extra olive oil on top of dishes. Add some tolerated sauces on top of dishes. One of my favorite go-to recommended ones is, a mixture of tahini, which is like sesame seed butter, water, garlic, and lemon juice all mixed together. Um, you can also make homemade baked goods to snack on, such as, banana bread that's sweetened with date syrup. And then you could add your favorite smooth nut butter on top for added calories. Personally, I like having a whipped cinnamon walnut date butter on top, but any will do. And then, yeah, definitely adding in some nut butters or seeds or seed meals or seed butters into meals. Um, a quick example could be chia seeds or cashew butter in some overnight oats. Next, oh yeah, this is next slide. Okay, and then what can you do to prevent inadequate protein intake? So protein is a macronutrient found in certain foods that's essential for building and repairing tissues and also performing various functions in the body. As I previously mentioned, it's also a nutrient that's involved in wound healing. Examples of better tolerated protein rich foods include seafood, lean chicken, and turkey, eggs, tofu, lactose free, fat free Greek yogurt or kefir, pureed legumes, and smooth nut and seed butters. Keep in mind that some of these are not going to be well tolerated for certain people, and yet other people are going to be able to tolerate all of them. So it's very hard to give specifics when everyone is very different and individualized. In general, it can be really helpful to consume protein with each meal or snack. But if you're consuming animal-based protein at least twice daily, you're likely getting enough protein. If you're a vegetarian or vegan, you may have to pay extra attention to the protein in these foods, in your foods to get enough. In those cases, or even for people who are eating animal-based protein, you may benefit from an oral nutrition supplement or protein supplement to get you enough protein so you can have enough throughout the day. So now let's talk a little bit about micronutrient deficiencies, which are vitamins and minerals that we need in smaller quantities to function properly. Common micronutrient deficiencies in people with IBD include iron, vitamin B12, vitamin D, and folate. But for those who have malnutrition, those who have poor wound healing, those who have small intestinal inflammation, are at an increased risk for certain nutrients, such as fat soluble vitamins like vitamin A, D, and K, selenium, vitamin B6, zinc, vitamin C, and vitamin B1, which is thiamine. And individuals with prolonged loose stools are also at an increased risk for zinc or magnesium deficiencies. Micronutrient deficiencies are important to watch out for because not only can they contribute to additional symptoms and decrease your overall quality of life, Some nutrients, like vitamin C and zinc, are actually involved in wound healing, and others, like vitamin D, is actually associated with potential increased risk of flares if you're deficient. Fatigue is definitely the most common deficiency symptom, with up to 72% of people with active IBD and around 50% of those in remission experiencing fatigue. It can be quite debilitating and is often untreated. So, treating nutrient deficiencies could actually be the answer to gaining more energy. And this is just a list of a few, this is a few examples of some signs and symptoms of nutrient deficiencies. But if you're able to work with an IBD focused dietitian, hopefully they will be able to do an in-person or virtual comprehensive nutrition focused physical exam where they're going to be able to ask you a bunch of questions kind of head to toe looking for signs and symptoms of nutrient deficiencies, and it's going to be a lot more comprehensive than this list. But that being said, if you have any of these symptoms listed here, talk to your IBD dietitian or your provider about whether it could be related to a nutrient deficiency. For example, if you have bleeding gums, your dietitian may ask if you also avoid fruits and vegetables because, or you cook all your fruits and vegetables because that could be related to a vitamin C deficiency. So, what can you do to prevent or manage nutrient deficiencies? You can use diet, supplementation, infusions, or injections. Um, let's start with diet. So, ideally, you want to try to aim for a diet that's as balanced as possible. If you're not sure how to do this with active disease and symptoms, definitely try to reach out to a dietitian that you can work with. For supplements, it's ideal to take a comprehensive multivitamin in what on a daily basis, just because you are at an increased risk for having nutrient deficiencies. Um, okay, there we go. And if you're supplementing any nutrient, just keep a few things in mind. So, number one, it should be prescribed because taking supplements preemptively could actually lead to toxicity in certain nutrients, or it could cause deficiency of other nutrients. So, make sure that your provider recommends a nutrient, like when they're recommending a supplement, that you're writing down the amount, the form, the frequency, and the time you should be taking it in relation to your current medications or supplements. Keep in mind also that taking more of a nutrient isn't always better. For instance, if you take too much zinc, that could actually lead to nausea. And some nutrients actually compete for absorption, so they will need to be taken separately from others. For instance, calcium and iron will need to be taken separately. And if you take too much zinc, that can actually increase the risk of having an iron deficiency. Also, when you're looking for a supplement, you want to make sure that the supplement has been third party tested. This means that a third party came into the supplement factory, made sure that what is listed on the label is actually in the bottle. Not all supplements are tested by a third party, unfortunately. So we basically have to advocate for ourselves and find a supplement that has been. One easy way to do that is just look for a supplement that has a USP or NSF label. It's also helpful to look for potentially triggering or pro inflammatory ingredients. These would be listed in the nutrition facts section under the ingredients. Some examples would include things like maltodextrin, carboxymethylcellulose, lactose, polysorbate 80, titanium dioxide, and sugar alcohols such as xylitol. So let's talk a little bit more about preventing and managing deficiencies through infusions and injections. So, one study found that up to 90% of people with IBD experienced iron deficiency. And I think a lot of people think that if you're not anemic, your iron is fine, but that's actually not the case. Iron deficiency anemia is actually a late symptom of iron deficiency, and iron deficiency, even without anemia, can cause significant fatigue. During active disease, guidelines recommend iron infusions over supplementation for treatment because oral iron often causes GI upset, and iron infusions are significantly better and faster at treating the deficiency. Now, B12 deficiency is also common, especially in individuals with IBD who are vegetarians, have ileal inflammation, or who have had an ileal resection. And although most of these populations can actually tolerate oral supplementation, for the Crohn's patients who've had a history of ileal resection, you may require injections to actually treat the deficiency effectively. Like iron, B12 deficiency can also cause significant fatigue, so it should definitely be prioritized and treated. So, in order to better advocate for yourself, we wanted to share which nutrients you should be getting checked and how often you should be getting them checked. Um, Before we get into that, I'll talk a little bit about the calories. So, for calories, I don't typically recommend counting calories. Instead, we want to just try to have you monitor your weight trends over time and watch out for changes in your appetite or intake, or really the best are they're really the best ways of ensuring that you're getting enough. For protein, when you're in remission, as Lori mentioned, your protein requirements are actually equivalent to healthy peers, but during active disease, that's where our the requirements increase to 1.2 grams per kilogram a day or more. I wanted to actually give you an example of like what that looks like, because a lot of people don't know how to calculate what our kilograms are. So, in order to calculate your weight in kilograms, you want to take your weight in pounds and then divide that by 2.2. And then you can multiply that by the 1.2 to get the recommended grams of protein a day that you'll need if you have active inflammation. So, for example, for a 150-pound person, they are about 68 kilograms, and so their estimated protein needs would be about 80 grams a day. If you, just for reference, have a cup of chicken with lunch and half a salmon fillet for dinner, you're going to be all set with the 80 grams. Micronutrients should be checked according to disease activity. So when you have active inflammation, you want to be checking them every 3 months. And this would include at least an iron panel, ferritin, vitamin B12, folate, and more nutrients if you have other risk factors. When you're in remission, you can check them every 6 months. Vitamin D should really be checked twice a year, typically once in the spring and once in the fall. And for UC patients, really the B12 and folate probably can be checked annually instead of every 3 months, um, especially if your previous one was within normal limits and you don't have a history of deficiency. But if you have a history of ileal pouch anal anastomosis or the J pouch, you will likely need to get your B12 checked more often. Hopefully this was helpful. Next up, we have Dr. Gold, who will be presenting on hydration in IBD.
All right, thank you so much. Can everyone hear me? All right, so we're going to get started and talk a little bit about hydration in IBD as well as about various dietary factors for specific patient populations. Perfect. So how do you know if someone is at risk for dehydration? How do you know if somebody is dehydrated? So the patients who are at risk for dehydration are the individuals who are having a lot of enteric losses, patients with a lot of diarrhea and vomiting. Maybe they're not eating or drinking as much, or they may be made NPO or nothing to eat while they're in the hospital. Our patients with an ileostomy and a jejunostomy are certainly at increased risk for dehydration, and that's because of increased output and diarrhea. Some of our J pouch patients as well have difficulty with hydration, and certainly our short bowel patients. How do you know if someone's dehydrated or if you're dehydrated? A lot of our patients tell us that they're very thirsty. Their urine becomes darker in color and maybe less frequent, so they're not having as much urination. They have dry mucous membranes, so their lips are really dry, their tongue, their skin is dry. Some patients, when they're really dehydrated, start to get headaches and dizziness, lightheadedness. Some can have a rapid heartbeat. Some patients can get muscle cramps, can become really fatigued and irritable as well. So what do we do for dehydration in IBD? Most of my patients come to me and they say, don't worry, I'm drinking a lot of water and I still feel so dehydrated. And I say to them, let's replace the water with something better, something that's going to absorb really well, especially if you're having malabsorption. I use a ton of oral rehydration solutions in my practice, especially in our IBD patients at risk for dehydration. And what is an oral rehydration solution? It is just a mixture of water, sugar, and salt, and a little bit of electrolytes that basically improves absorption, that allows the body to absorb it in an optimal way. I recommend that patients don't chug this, but they sip on it nice and slowly throughout the day. And as I said, it's better than water, juices, teas, and coffees. We use solutions that approximate the World Health Organization when it comes to their sodium and glucose content. And the most common things I recommend in my office are drip drop and liquid IV. I also use some oral rehydration recipes. So if maybe these don't have the right taste for you, if you're looking for something a little bit saltier instead of something sweet, there are a bunch of oral rehydration recipes that we send to our patients that they can use to make various solutions that they enjoy to sip throughout the day. All right, so we're going to move on and talk about nutrition principles for special populations. First and foremost, patients with an ileostomy, jejunostomy. So the most important thing here is to utilize diet as a modification so that you prevent disease complications. And what are we looking to prevent? First and foremost, obstruction and dehydration. So when it comes to preventing obstruction, I always tell my ileostomy and jejunostomy patients to be modifying the textures of the fruits. That means that instead of restricting fruits and vegetables, which was very common for many years, we tell patients instead to change the shape and the particle size to make them safe for them to enjoy. So we want patients to be peeling and cooking all of their fruits and vegetables. I often go to the next step and have them making soups and smoothies. We'll give out lots of smoothie recipes. Pureed vegetable soups are great options. And then we have our patients avoid those really hard textures, so nuts, seeds, and corn. But instead of eliminating from the diet, the idea is that you just modify their texture. So instead of having peanuts, having creamy peanut butter. Instead of having whole cashews, having cashew butter. Instead of corn kernels, maybe having corn flour. So polenta, as well as grits or cornbread, corn tortillas are all great options. The next is you want to maintain dehydration, and we talked about using oral rehydration solutions. In these patients, you find that the more sugar they intake, so whether that's from a sweetened yogurt, a cookie, anything like that, that increases their ostomy output. And this is really true of solutions like juice and sodas and other sweetened beverages. So I'm really big in our patients with an ileostomy or jejunostomy to limit the amount of water, limit the amount of sugar solutions, and really focus on hydration with oral rehydration solutions. I ask my ostomy patients to monitor their ostomy output and most importantly, their urine output because I want to make sure they're getting in and absorbing enough hydration to maintain their kidney function. A lot of patients tell me that they'll take a vitamin or they'll take a pill and they see it in the ostomy bag, and this is very common. So usually we recommend a chewable multivitamin tablet for these patients for increased absorption, and I often use something like a Flintstone or any other hard tablet vitamin that they can chew down. And then we try to give patients a list of foods that can reduce gas, that can cause gas and odor, as well as increased ileostomy output. And then really also important to talk about what foods you're going to see in an ileostomy. So it's normal. A lot of our patients have cooked carrots and they still see some in the ostomy. And I assure them that that's normal and that we want them to be able to still eat those foods and not to worry about it. So short bowel syndrome, we could have spent the entire hour talking about short bowel syndrome, but we're just going to talk very briefly about this. This is defined for patients who have under 200 or 100 centimeters of bowel, depending on the definition. And the idea is that we really want to have small, frequent meals throughout the day. And then in addition, we separate the liquids from solids whenever possible. And that helps to prevent the kind of pushing food through the gut, slowing down the transit, and increasing absorption. We're always talking about focusing on complex carbs, and we use a lot of antidiarrheals before meals to try to help, again, slow things down and increase absorption. If patients have had a bowel obstruction or they have recent surgery, I'm very big about texture modification, changing that particle size, and getting patients to be able to eat all of these different foods that they were previously limiting, but just in a safe and modified way. It's important for our short bowel patients to maintain their hydration similarly to the ileostomies and jejunostomies. And again, I use those same oral rehydration solutions while limiting their sugar. These patients also benefit from a multivitamin, and again, we use like a chewable tablet just to increase absorption and limit the capsules in the stool. And for our short bowel patients, we're monitoring their electrolytes and their micronutrients very frequently. And once patients really get to a new equilibrium where their bowel has started to adapt, I find that they're able to do a little bit less. So they're able to not need as many frequent checks. Awesome. So we're going to talk a little bit about the J pouch. Again, we could talk about this for another hour. It's an area of love for me. But nonetheless, in our J pouch patients, this is an area where we have some of the best diet research, which is what's great. We know in our patients who have a J pouch that we want to encourage fresh fruit intake, as this has been associated with reduced increased episodes of pouchitis. And so fresh fruit can come in a variety of forms. There's no specific fruits that you need to focus on. It's really about a variety of fruits in a given day and making sure you're getting in 2 to 3 servings if possible. I try to have our J pouch patients reduce processed food intake and limit those food additives. So those emulsifiers, thickeners, carrageenans, we want patients to focus on home cooked meals where they know what's going into them. A lot of our patients tell us that they're having stools overnight, that they're really struggling. They're getting up at 2, 3 o'clock in the morning, and everybody needs their sleep. So we recommend limiting the food intake to less than 3 hours before bed, and that makes sure that you've really had that chance to empty the pouch out before eating. And I try to have patients have a starch with dinner. Sometimes patients are skipping it, but having a potato, some rice, some bread will help thicken that output and limit the number of overnight bowel movements. Many of our pouch patients are bloated, they're having a lot of gas, so we talk about limiting those cruciferous vegetables. I also try to have patients limit their carbonated beverages, not use a straw when drinking, try not to chew gum, and focus on those small, frequent meals kind of throughout the day as opposed to bigger meals more spaced out. And in patients who have had obstructive symptoms from their J pouch, maybe they have a known twist in the pouch, I use those same texture modification strategies of peeling and cooking all your vegetables, peeling your fruits, having soft textures on their proteins, having white rice over brown rice, regular pasta over whole wheat pasta if there are obstructive issues. And finally, for our perianal patients, this is an area, and unlike the J pouch, where there's almost no dietary data, and we're really hoping that this will increase over time. We do know that we want our perianal patients to focus on having a healthy weight when using a Mediterranean-style diet to do so. A lot of these patients do better with softer stools, and so we'll add some soluble fibers back to the diet. So oatmeal, some potato, avocados, cooked carrots, and we sometimes limit the insoluble fibers to limit the number of trips to the bathroom and allow that area to heal. There is some evidence in the wound healing literature about zinc and vitamin A deficiency in association with poor wound healing, and therefore we associate that with our perianal patients. And so we do monitor these vitamins and minerals for our patients and supplement them when they're deficient. Anecdotally, a lot of patients have told us that very hot and spicy foods can be irritating on the bottom, so we avoid things like really hot sauces and those other kinds of substances. And instead, but I want you to get flavor in the diet, so using green herbs and non-spicy flavoring is encouraged, and again, avoiding caffeine for the same reasons. All right, so I think I'm going to turn it over to Rachel for the key takeaways from today.
Sorry, am I reading the key takeaways or just going into the Q&A?
Oh,
Yeah, thank you. Great. So thank you to all of our speakers for a wonderful program. At this time, we'd like to resubmit the 2 questions from the beginning to see how much you've learned. So those poll questions should pop up, I believe. There we go. So please make your selection to the 2 questions on your screen now. Again, the first question is, how often should an IBD patient be screened for nutrient deficiencies if their disease is active? And this is followed by our second question, which of the following is the most common nutrient deficiency in IBD patients? Excellent. So the correct answer for our first question is every 3 months. We've learned that during active disease, nutrient deficiencies should be monitored every 3 months, whereas in remission, nutrient deficiencies should be monitored every 6 months. For our second question, the correct answer is iron. Other common nutrient deficiencies include vitamin B12, folate, and vitamin D. Thank you all for taking the time to participate in these polls. And now let's direct a few of the audience's questions live to our expert presenters. If you have a question for Lori, Brittany, or Stephanie, please type it in the Q&A box, which can be found at the lower part of your screen. Our first question is for Brittany. Can you please review the mineral supplements that compete with each other and should be taken separately?
There are quite a few, but the ones that I mentioned was how I think I mentioned calcium and iron, and also iron and zinc. Both they all compete for absorption. Zinc and copper compete for absorption. Zinc and magnesium compete for absorption. So there's quite a few that we want to watch out for.
Thank you, Brittany. Our second question is for Dr. Gold. We got a question from a patient who has had a resection and takes supplements. Is your body able to absorb those nutrients, or will you always be deficient?
It's a really good question. And a lot of this actually depends on the anatomy and the resection that you've had. So the various spots in the small bowel, kind of dictate where these nutrients are absorbed. And so the really important things to know are where was your resection and which part of the small bowel and how much bowel was removed. When you know those two things, you're really able to help guide patients to say, I think this may be a temporary thing where you can absorb after and we can improve absorption, or maybe this is something you need more lifelong. I have found in patients who take chewable multivitamins that they are able to increase their absorption, or if we utilize supplements that are outside of the gut, as Brittany talked about, whether that's IM, so injections or infusions, so that we can kind of bypass the absorption and improve supplementation.
Excellent. Thank you so much. Our next question is for Lori. Can you talk a little bit about triggering foods? How do you know if food, alcohol, or additives are causing symptoms or if it's just your disease?
Yeah, that's can be really tricky. And unfortunately, it's individualized pretty specifically to, each person can react to foods differently, whether they're in remission or in an active flare. Obviously, things can be misconstrued when you're flaring. Most often, you feel pretty awful during a flare and have multiple symptoms. So it can be harder to identify specific food triggers. But most often, I always tell my clients, if you're eating a diet pretty consistently and you can kind of almost intuitively sense that something is driving a discomfort for you, it can be very kind of telling if we use almost like this like trial and error or like almost treat it as a little bit of a science experiment where we take whatever triggering food. Maybe it's cow's milk, like fluid milk, right? And maybe it's maybe if we're identifying dairy products in general, there's a few things that can be driving some, inflammatory response or just symptom worsening of symptoms. We can remove that potential trigger food for like 2 weeks time and see how your symptoms change. See if they're alleviated, but also it's really telling the reintroduction of that food too, because again, it can be a timely removal and reintroduction. So many other things play a role in our chronic inflammatory disease response. Can be sleep, it can be stress, it can be all these things that are multifactorial. So most often, I think it's easy for us to blame food, right? And say, oh, this can be a triggering response. This food is tangible. I can remove it, I can see that value, and I can reintroduce it and see again the effects. That can be a very comforting thing, but sometimes it's not always as clear cut. So I would say, first of all, trial and error is a good thing, but also really understanding that it's not always food that drives these symptoms. And we have to kind of take into consideration the whole being. Have I been more stressed lately? Am I keeping up with my hydration, my sleep? All of those things play a role.
Thank you. And for our next question is for Brittany. We had a few questions about raw vegetables. Do you recommend eating raw vegetables or do you recommend sticking with cooked?
Depends on your tolerance of them. If you can tolerate them, I would definitely recommend consuming them. There's no harm. Unless you have stricturing Crohn's, you definitely want to talk to your doctor and care team about what is actually safe for you to consume. But outside of that, you can have raw vegetables as long as you can tolerate them. If you can't tolerate them, we still want to try to get in a good source of vitamin C, is kind of what I was talking about earlier, because cooking actually kills vitamin C. So if we're cooking, all of our fruits and vegetables, then we're really not getting any good source of that, and that can lead to a nutrient, the bleeding of the gums or any other type of deficiency symptom. So in that case, what I recommend is doing, yeah, maybe it's peeling the skin off of fruit and having some very soft fruit. You can always put fruits or vegetables in smoothies, blend them up. They're going to liquefy them. Those are really great sources. And then if you're not worried if you're getting in some source of fruits and some raw source of fruits and vegetables, then you can have cooked vegetables as well um, to add to your diet.
Excellent, thank you. And then one more question for Dr. Gold. What about alcohol? Should patients avoid alcohol?
That's a really common question that we get. So in general, in a patient who's in remission, who's feeling well, I recommend just standard alcohol recommendations in terms of consumption. We really want moderate consumption. Certainly there's some data from a Mediterranean diet standpoint about red wine and the benefits there. So you just don't want to be drinking anything outside of moderation. For our patients with active disease, or if they're kind of titrating their steroids and everything, I do ask them to hold off in that just acute period, because it's hard to know if they're coming down on steroids, maybe just started a new biologic, how much of their symptom is related to diet versus their active disease. And so I like to kind of limit it to the foods that we know that are the safest and not going to cause any symptoms.
Excellent, thank you. And our last question is for everybody. Where do you recommend patients look for a registered dietitian who specializes in IBD?
So I believe on the Crohn's and Colitis Foundation website, they actually have a link now. Is that correct? So you can
That's correct.
go there. Also, at some facilities, IBD centers, there might be IBD focused dietitians there. There's also private practices that also have IBD focused registered dietitians. So any of those options could be ways to look. Also, the AGA also has a directory on their website as well.
And I would just add, ask your provider. A lot of times the providers know of somebody. There may be someone either in your practice or maybe in an adjacent practice that they know of that they can refer you to. So just remember to ask. I think oftentimes the providers may not volunteer or know to offer it, but if you ask, they'll get you set up with someone.
Excellent, really valuable information. Thank you so much. So I think we're ready to wrap up. Thank you all. This was a great discussion. We learned some very helpful information today. As our program comes to an end, on behalf of the Crohn's and Colitis Foundation, we encourage you to keep learning about IBD and to visit our helpful educational resources. To learn more about everything we discussed this evening, please visit the Foundation's webpage on diet and nutrition. Here you can learn more about the diets discussed this evening, as well as malnutrition, supplementation, and how diet can impact your IBD. Additionally, we have a great resource for you to explore, our Gut-Friendly Recipes website. This is a database of recipes. You can search for dietitian-approved recipes based on diet, type of meal, or specific requests like vegetarian or gluten-free. The IBD Help Center is there to provide information and resources to patients, caregivers, and healthcare providers about inflammatory bowel disease. They're available by phone or email, as well as live chat, currently available Monday, Tuesday, and Thursday. If you're looking to connect with other patients and caregivers, the Foundation offers virtual and in-person support groups. The QR code at the bottom right of your screen will help you locate a support group near you. Finally, to watch previous webinars and expert conversations, please visit crohnscolitisfoundation.org/myibdlearning. I want to remind everybody to please fill out the evaluation survey that will be sent to you after tonight's program. We really appreciate the feedback and it will help us plan future programming. Thank you to our expert presenters and to our IBD community for joining tonight. Have a great rest of your evening.